Thank you. Hello. Thank you very much for the lovely invitation from OHIS to speak in front of you today about implant dentistry. So the topic for today will revolve around the atraumatic extraction procedures in preparation for implant placement, and we will explore several points associated with exciting anterior challenging cases. I am Konstantina Dina-Dedi. I am an academic educator since the late 90s and a prosthodontist with interest in aesthetic dentistry and implant dentistry. My background, I qualified in Athens, Greece in 1995, and I did my specialty training in the US, prosthodontics at University of Missouri, Kansas City, and then maxillofacial prosthetics and dental oncology for rehabilitation of patients with deformities from cancer or trauma at the University of Texas, MD Anderson Cancer Center. I worked for 10 years at University of North Carolina Dental School, training prosthodontic residents, and also leading the ITI Fellowship one-year program with emphasis in implant prosthodontic rehabilitations. And I'm delighted to be at UCL in London since 2007, where I look after an umbrella of programs under the label Aesthetic Dentistry, where we teach basically high-end interdisciplinary dentistry from small natural restorations to large rehabilitations on teeth and implants. Today, I'm delighted to also have with me one of my academic team members, Dr. Shelley Luthra. Dr. Luthra looks after the periodontal offerings for our programs and the hands-on teaching. So Shelley, thank you so much for being with me today. And before we start, this is our new building in the center of London, the Rockefeller building at UCL. And one of our skills lab where our dentists come and learn several techniques on phantom heads before or after having experiences of training in the clinic as well. So for today, what we have, the main points will be around atraumatic extractions and the importance of them in implant dentistry, especially on faster healing protocols. Very, very important to emphasize that each case involves its own bespoke risk assessment and decisions, especially anterior implant cases with a smile of high visibility. We will explore our team's favorite methods, tools, and materials, and we will see several cases with an established workflow for immediate extraction, placement, and loading of anterior upper teeth. So we will see these procedures step by step with cases, and at the end you are welcome to comment or ask questions. And we will also explore initially protocols and timelines post-extraction, timelines, cases where they need volume augmentation, soft tissue or bone augmentation, or faster healing protocols. So before we start, let's see what is our goal. Well, the success of implant dentistry is to give back to the patient the lost tooth or the lost teeth, but also make the implant restorations disappear as natural teeth among his natural dentition. So in the past, emphasis was on the healing of the implant and the surgical procedures, but now success requires a perfect development from A to Z. So aesthetic implant dentistry, as we like to call it in our team, we need to have precise goals and a very precise and predictable step-by-step plan to reach them. And the motto we like to use is start with the end result in mind, having a distinct decision of what is the restoration and how we want to finish. So the workflow does not differ from dentate cases Basically, we need to plan and select the type of prosthesis in advance, make precise preparation for the surgery to know about the volume of the area, bone volume, type of implant, type of connection, and what are the phases, healing phases in between, and what is the temporization, because we need to assure the patient has a temporary that is stable and attractive. And finally, when we finish the restorations, what is the recovery plan? What is the maintenance of success? So I like also to use the term, and this is what I recommend to my residents, choose your dream team. Choose the group of people who share the same vision, and the collaboration is smooth and helpful and complementary. So for our team, in addition to Dr. Luthra, whom you will meet in a bit, is Professor Francesco D'Aiuto, who is the chair of perio at UCL Eastman. And for my case is Mr. Sean Wilkinson, the master ceramist who works the prosthesis from the beginning, from the planning, the temporaries, the mock-ups, and then the final ceramic prosthesis. So let's go back to the scenario where a tooth is not going to be there. And we have two main groups, the recipe for success, either if the tooth is there and needs to be extracted, or if the tooth has been extracted and we have an edentulous space, is the following. We need to have adequate bone volume. And this bone volume needs to support precise 3D restoratively driven implant placement. So this is one of the articles I like to use because it's quite precise on what we are trying to achieve. So what we need to have peripheral bone 3D around our implant. And the implant, which is the new root for the intended tooth, needs to have precise 3D placement, depth, position, and inclination. And an ideal scenario would be the depth to be 3 millimeters below the CJ of the ideal CJ of the tooth we would like to recreate, and to have around, ideally, 2 millimeters of buccal plate bone, or at least more than one. So let's see how we can reach these parameters. So as we said earlier, we have two types of cases. The tooth will need extraction, and this is what we will explore today. And the tooth is not there, had been extracted, and we have an edentulous space. So before we start exploring, let's remember, restorative planning before surgery is quite essential. Prosthetically driven, precise 3D implant placement. And every case will need to have its own risk assessment. It's not a repetitive flow for everybody. So we need to see what are the risk factors, how can we avoid them, and what technique and timeline we need to choose. Let's visualize. We need to recreate teeth and surrounding tissues as realistically as possible. Through the cases, we will see temporization, as you will realize, is of major importance, and the right type of temporization. So let's think, what happens after an extraction? After an extraction, the bone surrounding the tooth doesn't stay the same. Unfortunately, it shrinks. And how is that happening? That's happening throughout the stages, from the initial blood clot after the extraction to finally the filling of bone in the socket. And we know the following. So we have 3D shrinkage, but the width shrinkage is more than the height shrinkage. So we have an example, a paper here that shows that in the first 3 months, we have 30% of the loss and about 50% bone loss of the initial stage in the first 12 months, with the majority of the resorption happening the first 6 months. How does that translate to numbers? We have some example numbers, but basically we need to find out that we need to remember that width is the problem. And what are the risk factors associated with that? The gingival biotype. So usually on thin biotypes, we have more affected sites. So we need to be even more careful and think about volumizing the site in advance. And the thickness, of course, of the remaining buccal plate. So what are the considerations in treatment planning? So we need to avoid compressing the post-extraction site with types of temporization that will compress the area. We need to explore, thinking outside of the box, methods that potentially would generate bone for us. Something that could potentially work, but unfortunately patients are not keen is an ortho-extrusion, even on a tooth that is condemned for extraction. Because basically by pulling it, by extruding it, we are bringing down bone volume. However, that takes time and also requires the constant maintenance of reducing the length. Augmentation procedures, especially on affected sites, are much more popular. And also, in the majority of the situations, not all the situations have intact sockets. So that's why at traumatic extractions, if we can at least, the initial extraction technique can assure that we protect what was there, it's quite important. This is a classic article that colleagues could explore, and we will talk about it a little bit later. And that brings us to timelines. So we have timelines. A desirable timeline would be to start to be able to implant on the same day, and potentially, if certain conditions are met, to load with a nice temporary on the same day. Other scenarios are having us to place the implant 1 or 2 months post-extraction. More affected bone defects see us approaching the implantation at 12 to 16 weeks, and large defects after 6 months from augmentation. And there is not a specific clear differentiation. It's not black and white. On a lot of cases, we need to assess what can help the situation. This is a helpful slide. It includes basically the classification of defects and time frames. And you can see on the first ideal scenario, what do we need to have? We need to have intact bone volume. We need to have a preferably thick soft tissue biotype. We need to have at least 1 millimeter of thickness on our buccal plate. And primary stability, we need to have enough bone so the implant is very stable when initially placed. And in these situations, we can approach with a flapless approach, which is also a less time-consuming and traumatic approach for the patient. So before we start seeing these points through cases, let's do a little review. So after extraction, the bone shrinks. Bone loss is greater in the buccolingual direction, and it happens the greatest in shrinkage in the first 6 months. So this is where we need to decide on our augmentation procedures. And even in the situations where an implant can go in the socket initially, that will not stop totally the ridge resorption. Let's start with our first case. Let's meet Yasmin. Yasmin is a young lady. She had a tooth that had been restored in the past. She had a crown, a root-treated tooth. And when she came to see us, the tooth was quite mobile. The crown was debonding from the socket. And the patient was quite frightened because it's a front tooth on a smile that it's quite prominent. Let's take a look. We assess all the scenarios. We see the gingiva graying and kind of angry around the tooth in question. And we see that before we start anything, we will need to start with a control phase. When we treat cases in our team, we like to divide the treatment in the following phases. Control phase, which is anything that has to do with perio conditioning, with taking care of caries or infections. Interim phases, when we are in temporization phases, or we wait for some augmentation or for an implant to heal. Definitive phase, when we complete the restorations. And finally, very important, recall stage, maintenance stage, where the patient is given their homework, how often to see the hygienist or their clinician for hygiene supportive therapy, how often to see their surgeon, their periodontist, or their general or restorative dentist. So Yasmin will start from control phase, perio supportive therapy. And of course, the crown, the tooth was breaking, and it was not salvageable, required extraction. So the implant was not placed without any other intervention here. So here, the first step was the extraction, augmentation, and a Maryland. So let's see, the tooth was extracted atraumatically. We can see the root. The socket instrumented for removal of any granulomatous tissue. We can see the gingival zenith and outline. Donor side, as the augmentation is being prepared. And then after closure, the patient took a metal composite Maryland that was adjusted not to apply pressure on the recently augmented side. Let's take a look with a video. So we can see the separation initially with a thin instrument, and then ultrasonic, slowly to separate the tooth. Care not to damage the tissues, the outline. And finally, removal with a vertical motion forceps movement, and then cleaning of the socket. And then preparation for the augmentation. The donor side on Yasmin's palette. Preparation of the specimen. Shaping. And positioning. And before the closure. and then membrane stabilization and closure of the site. So from all the phases of Yasmin, probably this would be the most involved. So the patient, that's the starting point, atraumatic extraction, the socket post-extraction. And this is the metal composite Maryland. And there is a reason why we would like to use metal composite Maryland, because this is something that we can use again. And also this is something that it's quite polished, it's not acrylic. And also we can adjust and modify with restorative composite by abrading, using silane, bond, and restorative composite that is very moldable, and also we can polish to very high standards. The cementation in these situations needs to be done in a way that it's retrievable. So usually what we do, we sandblast the wings, and we sandblast also the proximals of the pontic, and we use resin-modified glass ionomer cement on the metal, but we use flowable composite in lieu of cement on the proximals after we etch and bond on the proximals of the teeth. Why is that? Because we want it to be stable. The flowable composite provides tags that even if the cement fails on the wings, the tooth will move, but will not fall out, will not debond. And the patient will have ample time to come back to us for cementation. The resin-modified glass ionomer of the wings help us because we can remove it easily when the time comes for Yasmin to have the next phase. So the day of the surgery, the patient will go home. And then the next step will be preparation for implant placement after that. So you can see the initial healing, the patient comes back, and that case was treated digitally. So what we did, it's a quite easy workflow. The patient comes back and we need to have 3 scans. We need to scan the intraoral situation without the temporary in place. We need to scan the ideal wax-up. And why I say the wax-up and not what she has now, because initially we kept the Maryland slightly off occlusion. So we don't want to replicate exactly the same incisal edge tooth position. And finally, bone volume assessment, CBCT. So these are the items we need to do. So the patient comes back, we will remove the Maryland. You can see how it has relaxed. You can see how the oval configuration now is flattened, despite the fact that we had ovoid pontic there. The beading around the wings, we like to do the beading so that we can position the Maryland again at the same spot. This is the wax-up. This is our ideal tooth and the incisal edge position. So this is what we will scan. This is what we want to replicate. So we import the files to the design center. And then there is, together with the surgeon working the case, the selection of the size and length of implant. And we have the possibility to also request a prefabricated temporary in case we are able to load the implant immediately. So basically after the design stage, and you can see how the software imports the ideal tooth, the position, and the superimpose on the outlines of the bone on the scan. We can receive a stand for proper, precise 3D positioning, the implant of the selected size and configuration, and optionally we can order a temporary. So let's see what came, and then we can proceed to surgery. So this is the dimension selected for that case. And this is what we receive. So you see the stent and you see the temporary again, basically temporary without the connecting cylinder disengaged so that we can connect it intraorally. Yasmin comes back and now it's the implant placement. So you can see now the stent attached on the teeth. And you can see how the position for insertion of the implant is slightly towards the cingulum, not in the center of the socket. Let's take a look. So this is how the Maryland will be separated. It's a very easy process. It takes about 5 minutes. So with a thin composite diamond, we remove the tags. And then we insert a slot screwdriver on the beading where the wings have been cemented and the Maryland is out intact. So here the flap elevation. You can see the adaptation of the stent. And it makes the procedure quite quick. The implant is being placed through the stent canal. And at that time, the surgeon will tell us if it has the primary stability we need. So in that case, it was assured. And then we can proceed with fitting the temporary or making our own temporary. Or if there was a situation where there was not comfortable primary stability, or the surgeon did not have, engagement wall on the bony defect, then we can always go and reline and put the Maryland back. So when we do these procedures, yes, we aim, if possible, to give an independent temporary on the implant, but we have the plan B, which is our Maryland. So here the cylinder was used, and actually we just copied the wax up. Yasmin wanted to whiten her teeth and to do some other procedures. So you can see very easy with a copy of the wax up, we can make our own temporary, which you can see next to the prefabricated temporary from the system. So initially, because the soft tissues were flattened, we have these triangles. I don't like to close them initially because I want to give the opportunity to the tissues to relax around. The patient understands that, especially if the patient is amenable. And then we will do a final polish here. And absolutely important to make sure that the temporary is shy of occlusion. So when we bite down on maximum intercuspation and also very important, at lateral movements, there is no contact at all. The thin articulating paper drags out. And the patient, it's a quick procedure. It was much quicker than before.
It was very good.
Did you have any pain after?
No, not any pain at all.
And how do you find your temporary tooth?
It's very good. Yeah, I'm very happy with that. It looks like normal now, even better than my real one.
I'm very happy. The final one will be even better. You know that.
Yeah, thank you.
You are coming back to collect it, no?
Yeah, I'm waiting for that.
So quick procedure, it really builds the confidence of the patients because they have an independent tooth. So to summarize here, basically the technique, let's use one of the educational videos from Geislich. Shaylee, would you like to describe that? It's the similar situation.
So we just go around first probing to see what is the bone defect level and what is, kind of imagining what scenario will wait us when we lift the flap. Then we sever the connective tissue and release the periosteum. Then we do atraumatic extractions using periotomes or periosteal elevators. Just relax the PDL and then ease the tooth out. That is followed by debridement of the socket to remove any granulation. This also gives us an idea about, a feel of the defect. Then this is a procedure where we de-epithelize the wound margin because we don't want epithelium to be there. We want the collagenous matrix of the membrane to adhere to the connective tissue. The defect is measured, and then you have this, which is called the BIOS collagen plug. So this is moldable. You can wet it with saline or clean patient blood, contour it initially, and then once this is wet and contoured, it can be carried to the socket. This is compressible, so it's easier for you to just shape it and press it in the socket. This is used in conjunction with a resorbable membrane. This is BioGuide, which is pre-shaped here. You can see it's something like an ice cream cone technique, which Dr. Tarnok says. So the membrane is placed first, like we saw in Yasmin's case. Initially, the resorbable membrane went in. Then the bone graft is pushed in and compacted into the socket. And once the bone level is desirable to what we want it to be, we just bend the membrane over. After we've undermined both the, in the initial surgery, we undermined the tissues, as you could have seen in Yasmin's case, which allows the membrane to be placed from the buccal, pushed and sealed towards the palatal. And then there are crisscross sutures placed to allow stability. In Yasmin's case, there was another thing which was done using the graft from the palate, which was again kept over this to cover up that area. That's called the socket seal technique. So it kind of regenerates the epithelium also. And so this is bone GBR done back for you. If we do not do this, then you can, as you can see, that there's compression of the bone moves more towards the lingual plate, so you don't have any space to finally plan an implant in the future.
All right. So that let's try to see a shopping list. So what do we need to have? We need to have thinner instruments, periotomes or laxators. Sometimes it's easier if we use some piezo instrumentation, and you saw that at the beginning in Yasmin's case, and forceps to collect basically the tooth, the extracted tooth. So this is one example of tools that they are quite preferred by a lot of members of our team, the general medical laxator sets, and the forceps set, and examples of piezo. Now, there are other tools in the market, especially for colleagues who are not involved in a lot of surgical procedures. And I'll show you an example that has been quite popular among my residents. So let's see a case. That was a case that was supervised and handled by one of my second-year residents. And she was planning to extract the premolar, but she was trying a crown on the canine of this gentleman. And as she was removing her temporary, there was something happened accidentally, and the tooth cracked. So she comes and says, well, we need to offer options to the patient, but the canine cracked. And you can see, yes, this is the area where she was planning to work, but now she acquired the new site. Let's see the gingival zenith here. Symmetrical with the other canine. And obviously, we would not desire an immediate huge recession of that area. So, like on every case, we have to go through options with the patient. We could explore extrusion, or crown lengthening, but crown lengthening will totally affect negatively the outline. Root treat and give a post-encore. However, the ferrule effect here was not enough. And a new crown, ceramic or PFM. A bridge, which was not a very good option here, given the fact that the neighboring teeth would go. Extraction and possibly immediate implant placement if that was permitted. So the patient opted for implant tooth replacement. You can see a long root, quite a robust root. And my resident is getting ready. And she used this kit. Now, there are similar kits in the market, and I will show you a few after that, but this one has been around since the 90s, and it's quite easy to work with. So what does it have? It's the same concept as extracting the cork from a bottle of wine, basically. So what do? The remnant, even if it's at gum line level, it gets flattened, and we can do that with a diamond. So this is what happened in this situation. And we are very careful of the thin buccal plate that we need to preserve. So flattening of the remnant. And then, obviously, after anesthesia, preparation of the post space. And the tooth was not root treated here, so we know that it's going to be extracted. So the kit has a few sizes that we can use, and we need to match with the pin that will fit on the flattened area, as you can see. So the pin is quite long, and now we will use the small tray, a quadrant tray that comes with a system, and we can use some heavy body silicone for cushion, because the tray will act as a leverage when we are trying to push and break the ligament fibers. So the whole extraction time is less than 15 minutes here. So my resident positions the tray, the pin sticks out, as we can see, and the extractor adapts there, and with by turning the knob, there is pressure applied, pulling the tooth out slowly and slowly. So there are after some awkward seconds, we usually hear a noise, and we need to notify the patient, because this is what the patient cannot expect, that something like that will happen. And we turn, and you can see how the edges of the extractor distance. And the tooth is ready for collection. Long root, clear cut extraction. Ready. And now we can see the socket. We can clean any granulomatous remnants. And then the instrumentation can start for the implant placement. And if you take a look, look where the preparation of the socket happens, towards the cingulum, not in the center. It's very tempting to go in the center, but we shouldn't. The implant is ready. And the horizontal defect is closed with some bios and Colaplug here. A prefabricated abutment is used. And a temporary is created conventionally. And you can see the outline after 1 week at the 1 week review. So it's quite attractive procedure wherever it can be selected. And let's see this particular kit, which, as I mentioned, is quite user-friendly. It's marketed by Titan. And let's see the video they provide with the animation. Let me try to...
This movie shows how we can remove a tooth with the Titan surgical system. First, the broken part of the tooth is removed to provide a flat surface. Then we use increasing size drills to create an area for the post to be placed in the root canal space. By slowly increasing the size of the drills, we prevent fracture of the remaining root. The proper size post is then selected in order for the tray to be in the right position in relation to this post. The record line must be at or above the height of the tops of the adjacent teeth. The post is screwed into the prepared canal space with a hand wrench. The tray is checked to make sure the record line is at the level of the tray opening. Then the impression of the adjacent teeth is taken to that level. The extraction tool is then fitted on the tray and post. By slowly turning the knob on the one end of the tool, the instrument lifts the post and, of course, the attached tooth with only a vertical force. As it lifts the tooth from the socket, it breaks the periodontal ligament that keeps the tooth in the socket. Now the extraction tool and the tray are removed. The tooth, which is loose in the socket, can be easily removed with light finger pressure. This is a very atraumatic way of removing a tooth without damaging the soft tissue or bone around a broken tooth.
So quite attractive, I have to say. This is what it is by Titan. And there are similar systems in the market. I know a lot of clinicians in the UK, they like this one. I know Shaylee likes it. So I won't tire you with a video, but basically, because it's a lot of narrative, but basically this is how it looks.
Is connected to a bumper, which acts as the fulcrum that is placed deep in the vestibule. The other handle is connected to the beak, which is positioned on the lingual or palatal root of the tooth into the gingival surface. No aspect of the instrument grasps the ground, and there is no advanced elevation needed. Once the instrument is properly placed, the handles are rotated a few degrees with only wrist movement in a slow, steady, and controlled manner. This position is kept from a few seconds to 1 minute or longer, followed by eventual increments of pressure of 15-20 seconds. The constant and steady load on the tooth allows creep to build, releasing hyaluronidase and resulting in the breakdown of the periodontal ligaments. Once the tooth is free and lifts a couple of millimeters from the attachment, it can be removed using a tweezer or extraction forceps.
So something similar as well, okay? So just this one uses manual pressure and lever, and they have them in various options for different sides of the mouth. And there is a similar tool like the first one by Zepf, a little bit more complex, which is along the same lines. So either the classic, so to summarize for the atraumatic technique, it's either the classic technique with thin periotomes separation and then, collecting it with the forceps, or any of these gadgets if you would like to try. And that is an excellent opportunity for us to discuss immediate placement and loading scenarios that I can't emphasize enough that they need to be assessed per case. And we can't, when we present it to the patient, because it's a very attractive option for the patient, shortens the healing times, we always need to let them know that we need to have plan B. If any of the points that I will mention cannot be met, we need to revert to a Maryland or something else. So this is what we need to do for immediate loading. Basically, we start with atraumatic extraction. The socket is instrumented at the cingulum level, not at the center of the socket for anterior upper teeth. Implant is placed with primary stability, some abutment, and the temporary is fabricated of occlusion. And when we talk occlusion, not only maximum intercuspation, but also especially laterals. So what is the recipe for success for this? Because the technique has been criticized heavily because if the proper points are not met, then we can have very anesthetic results. But let's see what we need to be careful of. So the atraumatic tooth extraction, that's a given because we need to maintain the buccal plate. Site evaluation for quality and quantity of soft tissue and hard tissue, basically the proper volumes. Morphology, we cannot have presence of pathology in the socket. And the implant placement very precisely, restoratively driven, 2-3 millimeters deeper from the CJ, parallel to the adjacent tooth with primary stability, and osteotomies 1 millimeter palatally from the center of the socket. Now, when we have thick biotype, this is a perfect scenario to try the technique because it's more forgiving. But let's see a few examples to see what happens in different variations. So here we have a thick biotype patient. The upper right one, the 11 has to go. That's the tooth in question. The patient has crowns on the rest of the teeth. The zeniths, not 100% symmetrical. Very, very important to point out the aesthetic evaluation to the patient because the patients become more dentally aware through the treatment and they start noticing discrepancies on the papillas, the zeniths, the gum outlines, and they ask. So I always review a photo like that with my patient and say, take a look at here, these are your papillae, this is where you have space, this is the oval outline of your gums, so that we bring it up. So here we had shortened but present papillae. That's the zenith between the centrals, laterals, and artificial crowns. So this is the situation. So tooth with a post, which is a classic situation. And again, we share the options with the patient. Removal of the post, retreatment if it's possible, new post and core and crown, but not indicated here. Extraction and a bridge or a partial, which the patients never go for a single tooth anterior partials, at least the majority of them. And implant tooth replacement. So according to what we discussed earlier, atraumatic extraction, 3D placement, cingulum, flapless approach, obviously, depth 2 to 3 millimeters from the crown margin. And when the procedure finished with the final restoration here, you can see, look at the healthy tissue around the crown. And the implant. Let's see the second scenario, a little bit more complex. This gentleman presented at the emergency cases of the university, and he said, well, there's something going on with my gums. They have been uncomfortable. I have a crown. I don't have crowns on the rest of my teeth. Now here, different levels on the zeniths and a little bit more complex. The tooth is sitting slightly forward. That means we have less width here. Presence of short papillae. Thinner biotype. Let's see what is going on. Crown next to intact teeth. Incisal embrasures that they are not symmetrical. That's another thing. Zeniths and embrasures is something that the patients assess. And again, we have a tooth with a quite robust post, a root fracture situation. And we go through the options: extraction and a bridge, a Maryland, or a traditional one, which is unfortunately more invasive, partial, or implant tooth replacement, a new root with a new tooth, which the patient desires. So something else that we need to be careful of, deep bites. Deep bites, sometimes even the Maryland option is a little bit more complex because we need to do traditional preparation for Maryland rather than have the wings raise the bite. On deep bites also, we need to think twice before doing immediate loading because it's impossible in some situations to protect the crown from early loading. Atraumatic extraction, the socket, same recipe, instrumentation, proper depth, parallelization with the other central, cingulum, not the center again. Placement, 2 to 3 millimeters deep, and selection of a prefabricated abutment, the taller one in that situation. And fabrication of a temporary, similarly to as if the tooth was a tooth preparation. We can see the Omnivac, some bisacryl. And very important here, we need to reline the margins. And I like to keep some replica abutments, and we can reline directly if we have bisacryl directly with Flowable because it has air inhibited layer and it sticks. The two materials stick due to the similar chemistry. We polish, and if we use a cementable option and not a screw retained, cementable option is quicker when we do immediate loading. It's much easier for us, less time consuming. So the only thing we need to be careful is that if we don't have a custom preppable abutment, we need to apply temporary cement away shorter than the margins. We can't risk having a lot of excess. The temporary. And when we place it in the mouth, very important, we need to check the occlusion. We can't afford any occlusion here. So before we polish it, we check. See on the protrusive here, the patient was guiding a lot. We need to relieve it, even if the temporary gets shorter. And then we polish. And the patient comes back, let's see a week later. Very attractive because we maintain the initial architecture. Let's take a look. The gums relax around it. And we can see here, the two first photos are day one, the day of the surgery. And the last one is a week later. And the final metal ceramic crown in about 10 weeks. And before and after. Now, the next scenarios are a little bit more complex because here we need to think outside the box and see how the technique can be used. So this gentleman, thinner biotie, had an impact and had a root-treated tooth that broke. And we can see that here we start with something that may have been compromised for his aesthetics, but for us it's quite convenient. We have papillae. The tooth is not there. We have different levels on the zenith, so we need to let him know about that. And we have the root-treated tooth with an retro inclination. And we go through the options. We had a defect already. It's possible the tooth was cracked. And let's see the technique. So we know here, we knew that we had a portion, and you can see when we measure with a probe, we had a defect on the buccal plate. This one, whatever is below the probe. So we know that we will have recession. But here it was something desirable for us. It's here we will accept the technique because a recession actually it's good for this particular patient. Large defect. Look at the difference in the instrumentations. And the implant has primary stability, a long implant was used, but we have a large defect. And we go back to the literature. So the literature, when the defect is more than 2 millimeters, we need to graft. This is a classic article, Hammerle and Wilson, management of the horizontal defects. Smaller than 2 millimeters, we can get by without. More, we need to do adjunctive augmentation. And thin biotype, also adjunctive augmentation. And here I wanted to discuss again the article we mentioned earlier, the Araujo article. And when you read it, you see it was, they tried it with implants in dog sockets, but you see how the implant obliterates the socket. And you saw that when we gave the recipe, we stay away, we instrument towards the singular. So same technique, parallel to the other tooth, 2 to 3 millimeters. Abutment, horizontal defect that will be closed. You can see some bios and Colaplug. Temporary. And about 10 weeks later, a ceramic crown. At that time, I mean, now we have beautiful zirconia. At the time, we had an alumina crown that the value is not what we would like, but the zenith is not detrimental for that case. And the patient's smile line is favorable. So see here, we had something that would prevent us applying the technique in other cases, but for that particular case, gave the patient a very quick protocol for treatment. And now we'll see for adjacent implants, another case that is quite compromised and thought-provoking. So the challenge of the interimplant papilla and in the early 2000s, when the immediate loading technique was quite popular and we had K-series coming out and a lot of research invested, people thought, well, that may save the situation, but we know that it doesn't now. Adjacent implants are quite challenging especially when the biotype is thin, because at best we can get a very minimal papilla. So thicker biotypes like this one, we can get a pseudo papilla and illusion, and we can apply the technique more comfortably. And what do we know? We know that the papilla is short, at an average about 3.5 millimeters. So we need to raise the contact point of our crowns eventually to close the triangle. We know that the tiny bony speckle in between the two implants, which is about less than 0.5 millimeter, flattens totally if we bring the implants too close. So we want to assure at least 3 millimeters between the necks of the implants. That was the other rule. So if you look at the literature, you see that there are three main approaches. The textbook approach is site preservation, augmentation, then implant placement later, and then restoration. So it's a longer healing time, and still the papilla will be very modest. Immediate loading is not getting us any better here, unfortunately. It may give the patient a more stable restoration, but it's not going to regenerate papilla or give a more optimum papilla point. And there was a scenario that unfortunately we do not have prospective studies on because it's very complex as a scenario. It was presented by Block initially, and basically they recommended to treat each tooth to be lost separately with hierarchy. And in their article, it was 6 months apart. Now, the last study I was involved with in the States, we looked at immediate temporization. And again, we confirmed as well that we cannot, with early or immediate loading procedures, we can't have the beautiful outlines we get on single teeth with the technique. Let's see a challenging case. Sarah was presented also at the university clinics. It's an old case. It's like early 2000, but I enjoy presenting it because it makes us think. So the patient comes in, she says that, well, I know I have problems with my two front teeth. I've had a lot of work done in the past, and we can see the grayness through the tissue. And she says, I have visited many colleagues of yours, and I will not accept something removable. And I know sometimes there is nothing else we can do, but it's worth exploring. So what do we see? We see scar tissue. We see two porcelain jacket crowns at that time. We see some grayness, which we know that it's something going on there. We see totally different gingival zeniths. We have some short papillae. And we see that the size of the laterals is quite small. But one good thing that we see is that we see robust canines. So to us, it's important because remember occlusal loading. So occlusal loading is something we shouldn't forget. So Sarah's canines can protect lateral oblique adverse forces. So that was one crucial decisive point for the case. So artificial crowns, and this is the situation. So both teeth quite compromised. The one tooth was slightly mobile because we had caries underneath, quite underneath below the gum line. And the other tooth had lateral perforation, and Sarah said, well, every about 6 months it flares up and I need to take antibiotics. And unfortunately, we see that the precious bony speckle in between the two teeth is already gone. So we don't have many options for this patient. It's simultaneous extraction and a lengthy protocol with augmentations and perhaps a partial, which we don't like also because it would compress and the patient is not keen in having the learning pathway of a removable prosthesis. A bridge here, it's a bit tricky because a Maryland bridge from the laterals, due to difference in size, may not hold. And then implant placement, and let's see. So here, the team who worked on the case after the initial control phase, as we can see, decided to address a tooth at a time, starting from the one that needed urgent intervention. So the 21 was extracted. Same process. Cingulum. And here, primary stability, the preppable abutment was used, you can see here. I like that because due to its width, it expands the tissues a bit, And when we switch to the final restoration, we have some pseudo length of the papilla because of the relaxation with a reduction of the width for the rehabilitation. It's almost as if it expands below the gum line. Tooth, temporary, out of occlusion. A week later. And then 3 months later here, because we couldn't wait 6 months for that case, the other tooth had to go, same situation. We went through temporary abutments because, I mean, nowadays we have a lot of nice ceramic abutments or PEEK abutments to choose. See the papilla? Flattened, very small. And the final crowns, you can see that there is a minuscule papilla. This is a dried slide. So when we, the area is wet, is less visible. So the benefit from the technique was that the patient stayed on a fixed rehabilitation. And before and after. Now, what we don't want to do, and I'll show an example of a disaster here, we don't want to go chasing the bone. So here we start on the negative, on that case, huge void in the buccal plate. This is one of the examples that the technique is used violating the principles, and we have a very unrealistic outline of tooth. So the bone is changed, they try to find primary stability, which they will if they go deeper, but at the end we end up with a long tooth and an unattractive outline. So we don't want to do that. That would not have been a case for immediate loading. And let's finish with some two last cases that they present challenges so that we see how we can think of the case and see the risk factors. Young lady, she had a history of falling out of her bike. One tooth was restored with root canal, post and a crown, and you can see, and the other one was devitalized but kept. And there was a root fracture, so she was about to lose the 11, and she's devastated. She said, well, my teeth, it's a prominent tooth. And we can see thin biotype, very, very dominant position for her centrals. But here we can't do the immediate loading because of the occlusion. We can't, otherwise we can't give her a tiny central that it would be quite unattractive. So here we cannot protect the anterior teeth. So she's not a candidate, and we tell her in advance. So here we did early placement. So the extraction happens first. And a month later, the surgeon who worked on the case proceeded with placement and simultaneous tissue management. So you see the tissue defect immediately. The patient opted for a partial here. If you do a partial, less and less patients opt for a partial, but if you do choose them, it's good initially to use CoaSoft because it's like lasts a bit longer. We need to change it about once a week, and it's thicker, so it acts as a cushion on the area. I wouldn't leave it more than a week though, because it hardens and then it will start applying pressure. So a month later comes in for the implant placement, and then she switched to a Merriman. We can see. Lengthier treatment here as well. And some soft tissue management was done when the patient went to a fixed temporary. So we go through a fixed metal composite temporary on the implant to give the opportunity for that to mature. And finally, the final zirconia crown after about 3 months here. Thin biotype, you see the papilla is not the lengthiest, but an outcome that she was happy with. And let's finish with some cases of larger defects. We'll see 2 remaining cases, and we see how these cases fall on the category 3 and 4. Obviously, we can't load immediately, and we need to do lengthier other procedures privately. So this patient, she was having orthodontics, and then something happened, we don't know, and the wire disengaged or something like that, and she ended up having one tooth totally out of the bony envelope, and the other tooth tilted, the canine, as you can see, in an unorthodox position. Unfortunately, the lateral could not be kept, and the defect was huge. So here, what we need to do, we can't proceed immediately because there needs to be an initial orthodontic movement on the canine side and on the central. So the extracted tooth was shaped and attached on the tilted canine until the patient sees the orthodontist, and then it was replaced by a tooth attached on the ortho wire. And then the patient comes back. There was a large defect there, and the defect needs to be reconstructed first. And then after close to 9 months of healing for that case, implant placement. So you can see the augmentation process. Some bleeding points, the segment stabilized, soft tissue. And what I like to do in these cases is that nowadays, because usually we have less space due to manipulation of the tissue, I like to go and fabricate chair-side Marylands, pro-temp, bisacryl Marylands, because we can discard them after the initial healing and then proceed with the proper Maryland that we won't need to mutilate during these procedures. So they hold quite well. We can polish them like a filling. We don't need to involve the lab in that, and we can modify them. And then as a last stage, the patient received the implant placement and additionally soft tissue addition. So it's quite complex case, although being a single tooth. We remove. Same technique from now on, like in Yasmin's precise 3D placement. And let's see her video. With soft tissue grafting here. So the bone augmentation happened first, and then the implant with soft tissue grafting. Flap elevation. Removal of the screws that they were holding the segment. The stand. Trial of the stand. Really precise. The stance is quite. They really cut down the surgical time. Okay. Proceed. Instrumentation. Going through the steps. And finally, the implant placed. And the harvesting of the soft tissue to amplify the volume for that side. And but again, lengthier process here, but necessary in order to have a more aesthetic result. And of course, it will be submerged, we wait, and we proceed later. Second stage, temporary, and final tooth. And we will finish with a quite, this is one of my favorite cases. I really enjoyed doing this case. We can see Wella because it really made an impact, and it's so fulfilling when you see that the patient gets what they aspired to when they came to visit the team. So this patient had a trauma about 7 or 8 years before she came to see us, and you can see she had lost a tooth during the accident. She had a quite traditional Maryland. And then she had observed dramatic bone loss on the other teeth. And this is a patient late 20s or early 30s from what I remember. We can see that we have a huge defect on the missing lateral for so many years. We have very little bone on the 11 and more than 50% loss on the other 2 teeth. There was slight mobility on the 11, but the other teeth were quite stable. It was that the patient did not like the appearance at all. She had visited many clinicians. Some people had tried to temporarily apply pink composite. Of course, its root surface adhesion is poor, and it doesn't give the naturality the patient wanted. The patient doesn't show tremendously the smile line, but the teeth look, the voids show. And the patient's job was such that she wanted impeccable appearance. Now we have a disadvantage here that we also need to be careful of. We have signs of wear, which are quite distinct for the age of the patient. Look at the facetting and abfraction. So whatever we do, we need to protect it really well. So the patient wanted more volume. She didn't want spaces. She wanted quite radically enhanced smile. So we start with a mock-up to try to see here in sagittal tooth position, because remember what we said, we need to augment based on having the final result in mind, and she wanted more volume. So we do the mock-up. We establish the length. This is just bisacryl mock-up from an initial wax-up. It's a starting point. It's not how we will complete. And then the first option, the surgeon who worked on the case wanted to augment radically. So the tallest points from the X-ray, if you remember, were the canines. So although if we didn't have aesthetic concerns, the other 2 teeth could drag on, could stay on. Here they had to go because he needed access to the tallest point for his augmentation. So extractions. And the day of the augmentation, he had pre-ordered a mesh, titanium mesh for the top with the outline of the volume he needed. This is one of the cases of the larger augmentations. Donor side here from her chin. And he will augment additional materials. This is the titanium mesh, and then it will be covered with tissue. And that was the most difficult portion because you see, immediately after these procedures, we have very little volume. Usually if we have Marylands, we need to mutilate them. That's why I recommend the use of the bisacryl chairside Maryland here, because you can just throw it away after the initial resorption. Unfortunately, this overbulking doesn't stay. We have quite a bit of vertical defect happening after that. So that's why I prefer to put the lab-made Maryland at the review appointments. And then finally, after 9 months on that, new CBCT, new bone volume assessment, then she received hair implants with, again, simultaneous augmentation. Another Maryland at the time, modified. You can see the composite tags in between. Some more space because the lip attachment was near. And then eventually, after the healing, we go to a temporary on the implants in order to be able to assess the spaces and finalize the spaces. And the case was completed with veneers on the canines and premolars. So initially the impression here, temporaries, to establish how the feel is, the lip support.
Question.
Okay.
Any current treatment from a doctoral clinic? Answer. No. So,
And you can see more length that we received here. The patient is quite happy with the extra volume, more naturality, and quite a bit of stability.
they feel bigger, but that's what I wanted. So that's a good thing.
And the look.
Love the look. Love the look. I want to be able to walk into a room and be proud to smile. I feel like I can now.
I think we're getting there. Thank you so much. Thanks.
All right.
And the final prosthesis. So we explore several scenarios. What we have learned that a predictable, successful aesthetic results requires a bespoke approach. And of course, faster healing times and faster procedures, if we can do that, and atraumatic procedures really, really help. And I would like to finish with a phrase that was given to me by one of my mentors in the States many years ago. It helps when we start with the end result in mind. Thank you very much. I will stop sharing now. And I will invite Shaylee if you have any comments.
That was a very nice presentation, Dr. Dina. I was mesmerized throughout myself. And I would just like to tell these people that, you know, when we are looking at things, we have to sometimes not just concentrate on the white part. We might have to concentrate a little more on the pink part, where sometimes you just can get away with a little soft tissue grafting and then you get beautiful results. So sometimes you need to wait with some soft tissue and hard tissue grafting. That's like, you know, the stages Dr. Dina talked about, type 1, 2, 3, 4. So that's the key. You have to see, and like Dr. Dina said, plan everything, keeping the final picture in mind, so that, you know, for getting the ideal result, you need to generate not just the contours and the shapes. So the white aesthetics and the pink aesthetics should be balanced. That's the only thing I can suggest.
Thank you, Shaylee. We have the first question. How can we provisionalize a case similar to the one of Jasmine, like the first one, like a single central, okay, with crowns in the neighboring teeth? Okay, excellent. So here, I will start with a question. What type of crowns? Now, if there are metal ceramic crowns, I am happy, okay? Because I can etch the metal ceramics easily, the same way I etch the tooth. So metal ceramic crowns, they have feldspathic porcelain, okay? So that means I can etch it, but instead of using tooth etch, I will use hydrofluoric etch for 60 seconds, okay? So I will put rubber dam, I will protect because the etch is quite caustic, but I will etch and put my Maryland quite predictably. And what I like to do, I will not cement with resin-modified glass ionomer because it's not going to stay. I will cement either with flowable or, for extra stability, with resin cement on one wing and flowable on the other. Okay, did I cover the colic wasp? So if they are feldspathic metal ceramic crowns or Emax crowns, I can do that. If it's Emax crowns, I will etch for 20 seconds rather than 60 seconds, okay? And if you notice, I won't put resin cement both sides and the proximals. I will use flowable, all right, on the proximals and on one wing, because flowable, I can break it off. It's like a weak resin cement. Now, if they are gold crowns, obviously, I need to figure out something else, okay, because I cannot bond onto them. But if it's like ceramic crowns or metal ceramics, I can use them. Any other question? And you guys have my email, or you have Valeria's email. So if you have any other questions, we are more than welcome to receive them through email. No, but yes, of course, yes, we are waiting. Temporization is important, as I mentioned, because for two reasons. First of all, you can use it to shape the tissues, but also, especially in the very competitive practice world now, the patient needs to feel secure and needs to feel attractive at every stage. So a temporary has to look really good. And it's easy to do that. We just need to use modern composites, indirect composites, which are easy to handle, nicely polished, and we can layer them with filling material, basically. I have stopped using acrylics for my temporary since early 2000. Shaylee, did you have a comment? Anything you wanted to add on the surgical side?
I would just like them to know that there are a lot of biomaterials which are available, which I just would like them to know. There are some things like I already discussed this BioOS collagen, which is from Geishlish. You can mold it. Then you have granules where you can pack them. Nowadays, like titanium customized, we can get membranes which are customized out of bone, which is coming from the biobank, the cell and tissue biobank in Australia. So you send the CT and CBCT of the patient, and then they'll mill and sterilize and send you a customized ridge, something to just place on the ridge, and then you get the bone graft. So that's for large defect sites. So there is a lot of options which are available. So they can explore that with their periodontist to see what is the best result they need to get, which is least time consuming and less traumatic for a second site surgery. Maybe if the patient can afford it, then why not? So that is there. And then there's a lot of membranes which you can use just in case, you just want to hold that space. Say, for example, you have a pregnant patient who fractures a tooth and comes in, and you can't place an implant, but you need to save that bone. So you can always graft that socket and do something like a socket seal with either harvesting it from the palate, which might be traumatic to the patient. So you get materials like mucoderm or mucografts, which you can just suture and put it there. So it kind of seals the area, maintains the bone volume for you. And then later when the patient can undergo radiation and then can undergo implant placement, so you can do that. So there are a lot of things, different case scenarios, which you can imagine and come up with options. So you feel free to send any questions if you have any queries about any particular case scenarios you have, and we'll try to help you out the best way possible.
yes, the biomaterials and the preservation and everything, it's a whole different lecture. So. All right, okay. As I mentioned again, feel free to contact us if you remember something, and I would like to thank you very much. Just remember that dentistry, it's all about people, and it's very fulfilling, and enjoy what you do. Thank you very much again.
Thank you, everyone. Wish you all the best for your cases in the future.
Thank you.